Okay.
Okay. Well, welcome everybody to today's N3C Community Forum. And next slide. So we've got a couple of really interesting talks with some major action items associated with Ken's talk in terms of linkage. Presentation will be recorded. Use Q&A button to post your question or chat. We seem to use them relatively interchangeably. Next slide. And so I'm pleased to say there is no meeting next week, which is AMIA. So that's good. I was not quite sure how that would work. So that's good. There isn't. November 14th, impact of COVID-19 on clinical outcomes among acute myocardial infarction patients undergoing early invasive treatment strategy by Sula Mazimba. November 21st is Thanksgiving, and November 28th is HIV, COVID, and social determinants of health, leveraging N3C resources for an R01 by a bunch of folks who I think got an R01. Next slide. Okay. So we're going to start out with Ken, and I think Ken, there's some other people talking as well. CMS Data and N3C, and this is like an incredible lift. I guess Chris was going to introduce this. Chris, are you on? Yeah, but it's incredibly valuable. I mean, it really.
I am on, Joel.
Okay, so
wrong name attached to me, but that's all right.
Okay, well, we're flexible. Okay, so go ahead, Chris. You were gonna introduce Ken.
Well, actually, I was going to introduce Ziggy, but I'll introduce Ken. Ken Gersing, as you all know, is the scientific lead from NCATS for the N3C and has been working diligently and heroically in terms of ensuring that N3C can access CMS data, and let him tell you how that is working. Go ahead, Ken.
Right, and let me just add it. So you're going to introduce. Okay, I didn't actually. I was a little confused by that, but okay, let you do that. But let me just put in my 2 cents, because this is really, I think a huge thing, in the sense that getting sort of context on patients is really hard when you get snapshots, even though impressive 3-year snapshots from health systems. So the ability to contextualize what's going on is going to be huge, and it is an amazing achievement. So go ahead, Ken.
Oh, and thank you, Joel. So first, we'll go ahead and first slide. Before I start, so the folks presenting today are Tom Richards, who I don't think you all have met. I think most of you all know Shawn O'Neil. But before I talk about the CMS, I do want to, it would be, as usual, these things are really a team effort. And Stephanie, I want to just, the DH&I team has been an amazing, wonderful partner and getting this. I just have to call out specifically Stephanie, and because she has really burned the midnight oil, but there's been a lot of people, Palantir and many others. And just we have a short period of time, but for the folks on the Zoom, there's a lot of reasons that I think CMS is also a big deal. Just FYI, it's Medicare now in early 2023. We'll also have Medicaid data if all goes well. And the only thing I want to put a little background is that CMS is often, CMS investigators often know CMS, but they don't know OMOP. And then the flip side, OMOP people know OMOP, but they don't know CMS. And so this effort really not only is bringing in this data, but it's also bringing it in a harmonized, semantically and syntactically, putting this into OMOP. So we're trying to make so investigators can only have to know one model, and they can merge this data. So with that, we'll go forward, and we're going to be quick and I hope you guys are as excited as I am. So this is just the background. As you guys know, we started out with EHR data because CTSA is obviously it's a natural spot, but we do know that to get a complete picture, and using Joel's term, contextualizing a person, we've got to put them back together. So really, as N3C has matured, I think it's becoming more and more clear that it's not an EHR repository. It is a patient. It is becoming a warehouse of different types of data on these people. So so many of the team have been working on social determinants of health. I can't even name them. Just if you all don't know, we have 60 external data sets. The recovery team has had lots of new field of social determinants of health. It's really enriched. Viral variants have come in from various sites. Mortality is there, obviously the N3C data, but today, actually tonight, CMS will become also available. And you can see at the bottom, we're kind of working on vaccine data. So next slide. Thank you. So I just had to, so we have a honest broker, a linkage honest broker, and that's Reagan Strife, the folks who bring you Loink labs, but they are also the group that is matching people. And every Friday night, all the data that comes in, they look for deduplicates, they look for matches. And I don't know if you all have seen this dashboard before, but what it's showing is we're actually up to, I think, 31 sites now that are linked data. And that's what you're seeing in the map. We have about 40,000 deduplicated patients. We'll talk about that another day, because that's about to change. But what I wanted to say is the bottom donut is really the linking of the data that we were talking about today. But I just want to make people aware, but we're also linking people from different enclaves. So we know every Friday how many all of us people overlap with how many N3C and how many biodata catalysts. So we're moving towards our long-term goal is enriching that person, but instead of the data always being in N3C, like we're really talking about today, the hopeful aspirational future is that we'll be able to pull data from lots of different enclaves, and we are already starting that. So next slide. Thank you. So just a real quick, every time we do a linkage, there is always a little bit of a wrinkle, and CMS is no exception. CMS, the HHS agency, CMS will not link data. So we have we had to hire an intermediary, which is a group called Acumen, who's been a wonderful partner. In essence, they take the data and they put down a hash, the tokens that we've talked about. But that in the normal case, that's the honest broker would glue them together. But the agreement with CMS was a little different. We are only linking patients who are in N3C. So the data actually goes back and forth. The honest broker says, oh, yes, I have this person, or no, I do not. If they have them, those are the people we get data on. So that the two wrinkles are that it's only N3C. It's not all of, like mortality is all of America. This is just the people in N3C. And then it's linked, and it's kind of similar to what we're doing with the other things. So this is just the 5 steps, and I just wanted to show you the exception. Next slide, please. So now Shawn and Tom are going to talk a lot about teaching and support, how Tom's a subject matter expert, obviously, in CMS, and Shawn is a subject matter expert in N3C, OMOP, and everything else on Earth in N3C. But I am the official nudge. So we only link data, and this is super important, of sites that have given us permission. And so to launch CMS data, we always have to have a certain number of sites. That number varies depending on the data we're linking, but in this case, we do have our launch base for CMS data, our 12 CTSA CTRs that are allowing us to link the data, which is a really nice baseline. We launched mortality with 6 to put it in context. But I can only link it to beyond the 12 if your site says yes. So if your site has signed the linkage on its broker, I sent you out a letter last week saying, would you let us link to CMS? If you have not signed the letter, then Mike Carilla sent out a letter last week to the PI saying, hey, please sign the linkage on his broker and then allow us to link your data. So I'm really just asking you guys, somebody on your team got a letter from either Mike or myself last week. And I just encourage you guys to help us link more sites, because the more we link, the more valuable the data and the richer it is for everybody. So next slide. That was my advertisement for the day. This is kind of what I've already said. I won't get into the details. It's really in the weeds, but the CMS data is only with patients in N3C, and it's only sites that we have been given permission to link. However, if your data is, you went to a hospital or an institution, though it won't be linked to an N3C CTSA with the N3C num, you will still see that person's entire CMS visit. So it does fill in the visits. This is one of the reasons why it's so powerful. It's filling in the missing spaces. As we get more permission, though, we'll be able to show that, let's say UNC and Duke have both given us permission, that they're really one and the same. So I'm not going to get into the details of it, but the site permission is super important, and I'm just asking for everybody's help to see if we can get more of that. Next slide. I think that was my last one. And it is, and I'm going to pass it. Shawn, I'm going to say this even before I let you go. Shawn's going to talk about the DUR process, but I'm going to put in a plug. When you apply to the DUR and you want to use linked data, there's a new checkbox there that says CMS. Don't forget your IRB has to, it's a level 3. IRB's got to know that you're using CMS data, and the DAC has to have in the rationale that you're using CMS or any other data, or they'll turn you down. So I know Shawn's going to mention this too, but I can't tell you how important that is, so you don't get turned down. Anyway, thank you guys. Shawn, that's all yours.
I believe Tom is up to tell us
Oh,
about.
Tom, I'm sorry.
Yeah, hi everyone. Tom Richards here. I'm with Johns Hopkins. So I'll talk quickly because I have a number of slides to go through, and I want to make sure that we have enough time for questions at the end. So when I was asked to do this, somebody somewhere along the way told me to assume that the audience knows nothing about CMS or claims. I'm going to take that with a grain of salt and assume everybody knows a little bit. But I did put together a couple slides here. You can read them on your own about some of the history. And I'll just highlight some of the takeaways. So as you begin to work with this data, you may see Healthcare Financing Administration, or HCFA, or HCFA. That's really what CMS was called before they were called CMS. So you may hear, like old timers like me, say HCFA this, HCFA that. It's really the same thing, HCFA and CMS. So if we slip, that's what we mean. So CMS administers mainly 3 major healthcare programs: Medicare, Medicaid, and the Children's Health Insurance Program. Medicaid is the insurance for poor, disadvantaged. 76 million are enrolled as of last year. The Children's Health Insurance Program provides insurance for kids whose parents or parent don't qualify for Medicare or Medicaid, but they don't make enough to get insurance, commercial insurance or some other healthcare coverage on their own. So it's basically kids who don't have insurance. So it fills a gap of very vulnerable patients. We're focused on Medicaid here. On Medicare. Medicare really has 2 different types of plans. What's called the fee-for-service Medicare plan. That's like traditional insurance, like Blue Cross or Aetna. You can go to any doctor you want. You pay some, the insurance company pays some. Medicare Advantage is more like an HMO or preferred provider network. It'll pay most or all of the cost of your healthcare as long as you go to a provider who's in the participating provider or provider in the network. A takeaway here is that you see the numbers here, 36 million enrolled in fee-for-service and 28 million in Medicare Advantage. That's changing. If you were to look at that even just a couple years ago, that difference would be a lot bigger, a lot more people enrolled in fee-for-service. There's a huge move to Medicare Advantage for a variety of reasons. And it'll be this year and next year, sometime soon, that there'll be more enrollees in Medicare Advantage than fee-for-service. The important thing is when you hear that Medicare data is available, a question is it Medicare fee-for-service? Is it Medicare Advantage? Is it Medicare for both or both? In our case, we have the Medicare, what's circled here in red, Medicare and fee-for-service. So that's what I'll talk a little bit more about in the next couple of slides. So next slide, I guess. I mentioned before that Medicare enrolls people, or maybe I didn't mention it, but Medicare is primarily for people 65 and over, but you also can qualify and get Medicare coverage if you're under 65 and you have end-stage renal disease, ESRD, or you're disabled. And it's not insignificant. There are about 14% of the total Medicare enrollees who fall into that category. When we do have them, we have all enrollees. Medicare categorizes their services and their claims into parts, 4 different parts. Part A is sort of traditional inpatient services. You go to the hospital for anything from an appendectomy to a major heart procedure or beyond. You're in there for a day, or you're in there for a year or more. That's covered and by Part A. Also, skilled nursing facility services. So you're in a nursing home with a higher level of skill, sort of a specialized nursing home. Those claims are covered by Part A. Hospice, which is end of life, mostly end of life care, and home health, where the provider comes to your home to provide services. So in my experience, and I've been working with claims data for almost 40 years and EHR data for about 15, in a research environment, we tend to kind of lump skilled nursing, or sometimes called SNF claims, hospice and home health all together and just do aggregate. But as I thought about it more, home health in particular for this COVID cohort might gain in importance. There may be more done with home health than traditionally it's been done, but they're all available. Part B covers preventive services, what we sometimes call ambulatory services, and outpatient. So outpatient would be like a hospital. You go to a hospital for an outpatient department, you leave. Ambulatory is everything else that's not an inpatient. So you go to your doctor's office, you go get a blood draw, you go get an x-ray, things like that. There are some drugs that are also covered and included in Part B claims. Those are drugs that a patient wouldn't typically administer to themselves for a variety of reasons. Something like maybe like an infusion or cancer drug or something like that. Or it requires a special device to administer it, things like that. So you'll find those. And then also durable medical equipment. So those are things, people always say canes and crutches. I don't know how much of it is actually canes and crutches, but things like colostomy supplies or catheter supplies. I guess, wheelchairs, motorized wheelchairs and things like that would show up under DME. Part C are the Medicare Advantage claims. And if I didn't mention it before, fee-for-service nowadays is being referred to sort of as like the old Medicare, Medicare Advantage, new Medicare. So you might hear old and new, that's what it means. Part C, we don't have the Medicare Advantage claims. And then Part D is prescription drug claims, and that's been around since 2006. The other important thing about this slide, Medicare was signed into law in 1965. There's a lot of data. It goes back to 1965. It's out there, it's at CMS. They have a huge amount of data. When they changed to CMS in 2001, it also, it not just sort of coincided with their beginning to administer Medicaid, but they really started to not just administer the programs and process claims, but they started to do analytics and generate a lot more data. So there's a huge amount of stuff that's available from CMS. It's really useful in the research environment. Next slide. I'm not gonna dwell really on this at all. There's a site here where you can go and look and get all the more information than you probably want about comparing new versus old Medicare. The important thing here is what's in red, I think, at the bottom, that N3C is ingesting the Medicare fee-for-service claims and the beneficiary enrollment data. So I'll talk about beneficiary enrollment in a second. That's really important, and it's a big distinction between claims data and EHR data. Let's go to the next slide. So first of all, let's talk about what are claims, since I was told that people won't know this. This is my definition of what a claim is. Basically, it's a billing instrument. So the provider of the healthcare service is sending the insurance company a record that says what was done and I want to get paid for it. The insurance company may send it back and say, we're not paying this because of this reason or that reason. It's not uncommon to make a mistake on somebody's number or their name or something, especially in Medicare. We see that a lot, like a spouse's name is put down or a spouse's number. But anyway, the provider resubmits it. So there's a process. Claims go back and forth between the payer and the provider before they finally agree that, okay, everything looks good, we're going to pay this. That process is called adjudication, and that final claim is called the final action claim. And what we have in N3C is the final action claim. So we don't need to worry about adjudicating this stuff. There is a latency before you get sort of all of the claims are final, if they ever really are final. But that's changed over the years with technology. So, you know, it used to be a year, then it was 6 months you had to wait. The last I heard, it was about 3 months, if you wait about 3 months after the date of service. So, you know, we're coming to the end of the year. If we wait till April 1st of 2023, we can get over 90% of the claims that we would get from Medicare would be final action claims from 2022, from the prior year. So, so anyway, some other highlights about claims, and particularly in comparison with EHR. I think the next slide does this too. But claims are for billable services while the patient was enrolled. So I mentioned the enrollment file. Big distinction. You look at your EHR data and you have a patient who's in there and they had no services last year. What does that mean? Does that mean they didn't come in because they were healthy? Does it mean they didn't come in to see you at your health system, but they went somewhere else and had a whole bunch of stuff done somewhere else that you don't know about? Or does it mean maybe they lost their job and they were unemployed and couldn't afford to come in? So that's something you can't really tell in the EHR. We do proxies for enrollment in the EHR, but with claims data, you can tell that. We have an enrollment file that tells us each month of the year when a patient was enrolled, why they were enrolled. In Medicare's case, if they were enrolled, what's called dually enrolled, meaning they were enrolled in both Medicare and Medicaid. Why is that important? Because that means we might not have everything for that patient. There's some Medicaid portion that we might not have yet. And it tells you that for each month of the year. Claims also, in addition to telling you services that the patient received, they also tell you medications that the patient had filled. So both services and medication, big distinction between claims and EHR. You look at the EHR, and the EHR is telling you the doctor prescribed this medication for the patient, prescribed a statin. You don't know whether that patient filled that drug or not, sometimes in the EHR. If you have a feed from a pharmacy, you might know it, but a lot of EHRs don't have that. With the claims, you know that. What's on the claim is what occurred, what the patient had filled, and anywhere they went, not just your health system. So they went somewhere else for a sick visit, you're going to have that in claims. Vocabularies on claims are national standards. They're not in EHRs. How many of us have struggled to try to translate homegrown or internal codes from the different EHR systems to something that like a CPT or HCPCS procedure code, or to a ICD-9 diagnosis code, or even something like just a standard place of service code. On the claims, they're already standardized. Claims will have death date if the person died in a facility. You might not have that in the EHR at all. They contain charges and payments I mentioned. Now, we're not pulling that information in right now because of confidentiality reasons at the site level. But that's an advantage of claims. Claims don't have the depth of an EHR, so you're not going to have lab results. You're not going to have diagnostic imaging results. You're not going to have social determinants, except that some social determinants, food insecurity and some others are coded in diagnosis codes now. It's not always well coded, it's usually not, but at least there's a provision for that. But generally, you're not going to have that or text, clinical notes, or family history and medical history. You won't have things like that in claims, but you will have all diagnosis codes that providers assign to a patient, no matter where they went, all procedures that a patient had, all billable procedures that a patient had performed, where or what type of, at least what type of place, whether it was an office, an inpatient, a hospital, outpatient, you'll know that information from the claims. I mentioned that we have the enrollment. So let's go to the next slide. And these are some of the differences between claims and EHR. I think I've talked about most of these already. So a couple things that I did mention, advantages of combining the enrollment data with claims data, and something that also we really couldn't do with the EHR. If you're studying utilization metrics, how many visits or how many inpatient admissions did somebody have in a year? If you're studying cost, what was the total cost for a year? And you're getting that from the EHR versus claims. In the claims, we know a particular patient had one visit for $100, but they were only enrolled in the insurance for 6 months. We can use that information to annualize. So we might double that and say on a yearly basis, that's 2 visits for $200. That's usually a lot more complex than that, but I think you get the idea that we can use that information to annualize things and kind of level the playing field of a population. Or we might just say, and in Medicare, when people start Medicare, they typically stay on Medicare and they'll be continuously enrolled. So we might, if we're studying a cohort, we might define our cohort that we only want to look at people who are 12 months continuously enrolled. So we know for that cohort, we have everything. We have all of their claims for everywhere they went, all the drugs that they filled, and so it's a cleaner way, a cleaner cohort. The other thing I didn't mention is a difference between the EHR and the claims is that healthcare, particularly larger healthcare organizations, have billing departments, and they'll take the EHR data from the provider and they'll optimize it when they put it on a bill to the payer. And this is sometimes called upcoding, where, and in fact, there are companies and software that do this automatically now, and whole companies that that's their sole business model, is to optimize Medicare billing or Medicaid billing or whatever. And so there could be some differences between what you see in the EHR and what's on the claim. It's not incorrect and not fraudulent or anything like that. It's just additional information. So a particular visit, a provider might have coded that the patient had hypertension. When they bill it, maybe they'll put that the patient on the bill that the patient had hypertension and diabetes. I don't know if that's really would change the payment, but that's kind of like what happens. Next slide. So the CMS data in OMOP, I mentioned we had the final action claims. Ken talked about the patients and the linkages. So again, I want to reiterate, if someone agreed to participate, then that site has, or agreed to the linkage, that site has all of the Medicare data for all of the places that patient went, but you can't tell what those other places are. That information is masked. So, to use Ken's example, if Duke agreed and North Carolina didn't, Duke would see their patient and they would see all of the claims for that patient, but they wouldn't know what claims were from UNC or some other facility in the country, or somewhere in another state or somewhere far away or close. You wouldn't know that. I talked about the master beneficiary summary file for those of you who are familiar with CMS data. That's what we're pulling in N3C, and it provides, the things that I said, the enrollment periods, and some of these other things. And I think I've talked about all of those. So I think that's it for this slide. Let's go on, and I can sort of begin to wind up here. Here's some more information. So the center, the Research Data Assistance Center is the go-to spot at CMS for all of us who have used Medicare data, ResDAC. That's where you'll find a ton of information, and it's where to go to look if you want to know what certain codes mean or certain variables. There'll be some of that, I think, also accompanied with OMOP and N3C, but that's a good place to go. There's a link there about fee-for-service compared to Medicare Advantage. I may have given that earlier too. And then this one I don't want to dwell on too much. Shawn and I sat down late Friday and we decided I wanted to do something with the data just to see what's there. And the bottom line of this is that down at the bottom there, that there were about of the people that I would have expected to have CMS claims for, we had CMS claims for about 43%. That's a little lower than what I would expect. If it were closer to like 75%, I could explain, users versus non-users. But I'm not worried about this because we did this very early. It was preliminary. I think data was still being loaded. So we'll have to do this again. But anyway, those were the initial results. So that's it. Let me turn it over to Shawn now. Thanks.
Thank you very much, Tom. Yep, as Tom mentioned, these are really brand new data, hot off the press, and we're still getting familiar with them. I just wanted to point out a couple of our training resources that we've discussed in the past around PPRL, as well as some ones that are currently in development, specifically around this CMS data. So for those who aren't familiar, our privacy preserving record linkage thing is where we can link data from multiple sources without knowing those personal details, and that's how we're able to stitch together all these amazing different data sets. We had a previous community forum presentation on it way back in March, and you can check it out at that YouTube URL. We have some training materials around PPRL in general in the training portal in the Enclave, and so if you search for PPRL there, you'll run across them, including the brand new one that discusses the CMS data. There's a link right there to the main N3C PPRL site. And we'll also be doing a more in-depth webinar around this at the November 18th Enclave users group. And that's at 10 a.m. Pacific or 1 p.m. Eastern time. And you can find a link to that at our covid.cd2h.org/training page. There's one thing I wanted to highlight, which is what Ken had mentioned, which is that these PPRL data are only available alongside the LDS or level 3 DUR. And so this is live now. When you are able to, you can log in and fill out a new DUR request and select the limited data set, where you can update your current level 2 data request or current level 3 data request and add the CMS PPRL linkage. Note that when you do that, you need to let the DAC know why it is you are requesting that as part of your research project rationale. And because it's a level 3 project, you're also going to need to upload your IRB determination letter, and your IRB should be aware of the fact that you are going to be linking against the CMS data as well. And the Data Access Committee is going to be looking for that in those IRB determination letters. So do be sure to check out the training materials that we have coming up and in development, especially around the fact that, as Ken mentioned, some sites are agreeing to linkage with the PPRL data sets of different kinds, and some sites are not. And so you will find in the data that we have something that looks like, in this particular case, a CMS person ID, and it's going to be mapped into that OMOP schema. And then there's going to be a mapping file which relates N3C person IDs that you're probably already familiar with if you're working with N3C data to these CMS person IDs. And this is a bit different than some of the other PPRL dataset modalities we've dealt with in the past, and it does add some interesting complications for research, in particular that, there might be duplicated records in there. So a record in the EHR data might actually be duplicative with a record in the CMS data. And so you should be aware of what data you're including and not including when you're going to be joining these together for research. So all that said, I'm going to go ahead and move it on so that Siggy and others can talk about cool TermHub work, although there was one question that came in chat that I think Ken is probably going to want to answer live. Ken, how much does this cost? Oh, is Ken gone?
No, I'm sorry. I did answer the question in the chat, but like anything in N3C, it's free, free of use. Please let your friends know that it's a great resource, and we want people to take advantage of it.
Some. Okay, Siggy, do you want me to drive your slides for you?
No, that's okay. And I think Chris was going to say something.
Yes, I want to introduce Sigfried Gold, who's a senior software engineer here at Hopkins with us, working on terminology, content, and value sets. He has a long-standing history of working in value set management for clinical research and is pursuing his doctoral degree at the University of Maryland, College Park. He's going to be presenting on TermHub, which we believe and consider to be an important adjunct to concept set management in N3C that affords considerably greater functionality than is possible with the enclave alone. So with that, Ziggy, please.
Thank you. Let me share my screen. And get Zoom out of the way. So thanks, Chris. And yeah, so what's motivating TermHub, which is some software external to the enclave for navigating concept sets and doing some other stuff, are these we have a number of use cases to choose between similar concept sets for a given clinical condition or event, which is a situation that comes up often. If you want a concept set, or you're making a concept set for some study, you need a clinical condition, you're likely to find a lot of existing concept sets covering the condition that you're interested in, which would be great. Maybe that should save you a lot of work, except that often you don't know where to start. You don't know why there are several there and how they're different, or why they're different, or which you should use. So a lot of the motivation is to help you figure that out. The use cases are to choose between them, to author or modify them, to analyze or explore them. And also, we've heard from users who are developing their studies with clinical experts who don't actually have access to the enclave. So this provides a way to do that. With all these use cases, we want to be able to take advantage of what we call neighboring concept sets that have overlapping concepts. We want to be able to see easily which concepts are overlapping or not amongst those neighbors. We want to be able to see metadata like intention and the contributors and stuff like that. We want to be able to see the hierarchy of the concept vocabularies as well as counts. So with that, let me jump into the demo. Oops. And so to take an example, we'll take a look at neurological complications of diabetes. This is a drop-down with all of the concept sets. I'm going to start typing in diabetes or part of diabetes and neuro, and this gets me to three things. So diabetic neuropathy looks like about what I want. So I'll click on that, and that brings up that concept set with its 55 concepts and a list of 86 concept sets that have one or more concepts in common with it. I did see while I was typing that there were a couple of others. So there's this one that also has 55 concepts. So let's see about that one. When I look at precision and recall here, and the number of, I have a total of 55 concepts. Each of these have 55 concepts. It has complete precision and recall. These are identical concept sets. So I don't know why two of them exist, but perhaps if whoever made the second one was looking at this, they wouldn't have made the second one. So I like the title of this one better. So I'm gonna get rid of that one. And I saw there was something else here that looked like a possibility, neuro 3X diabetes. So bringing up that one, now I've got 87 distinct concepts. I've got 55 in the diabetic neuropathy, 32 in the diabetes. That seems like they might not have many shared. I'm not going to do the math in my head, but I will go look. I'm going now to the comparison page. And so I'm going to look at the comparison. Here's my column for diabetic neuropathy, my column for the neuro 3X diabetes. If I scroll down here, I see that they actually share no concepts. But so that makes me wonder, does the neuro 3X diabetes have anything to do with neurological complications at all? And I see type 1 diabetes mellitus is in there without complications. So this looks like a more general diabetes concept set, except now here I see poorly controlled type 2 diabetes with neuropathy. Well, that sounds like a concept I would want. And it does not appear in diabetic neuropathy. So if, for instance, we were editing diabetic neuropathy right now, we would not, we would want to include it. But I also noticed that it has no patients and no records in the enclave associated with that concept. So I'm kind of curious, you know, is it maybe this concept wouldn't matter in my concept set, but maybe related concepts would. I have links here to both Atlas and Athena. So for this concept, so let's go look in Atlas for this concept. And it turns out it's in the Nebraska lexicon. It actually is, I thought it wasn't a standard concept, it is a standard concept. If I go look at related, I'm sorry, at the hierarchy of concepts, it has no children, but it does have some parents. And one of those looks relevant, disorder of nervous system due to type 2 diabetes mellitus. And if we go to there, we'll probably find some interesting children. Anyway, just showing you that that's a convenient thing to be able to go straight from here to Atlas to Athena. I am going to, let's see. Also show you for the concept sets that I've brought up, we can export them. We've had requests, can I export and get my concept sets out of the enclave? The enclave already has ways to do that. This is a quick and dirty way to do that in JSON. We will also make ways of exporting to spreadsheets, which people will probably find useful. But one thing I will point out about it is when you do export the JSON, you're also getting the counts, the patient and record counts for the concept set as well as the concepts. And you can also go straight from here to open up this concept set in the enclave. And there are definitely things you might want to, there's a lot more information in the enclave that isn't yet in TermHub, so you may want to do that. I mentioned precision and recall here. So the way this works is that you select some number of concept sets. Let's see. I think they're like diabetes complicated might have some concepts in it that, that might also point us to things that have neurological symptoms that maybe didn't make it into diabetic neuropathy. We already suspect maybe diabetic neuropathy isn't perfect. So, and even if we didn't suspect that, we might, we would definitely want to look around and see what else we could find. So going to my comparison again. Oh, sorry. I meant to finish describing what precision and recall are here. So of these three concept sets, they have a total of 403 distinct concepts. And of those 403, the precision will be how many of the concepts in this concept set, the one on this line, are, what portion of them are part of those 403? Well, for a lot of those, that's 100%, because a lot of these are subsets of the union of the three concept sets that we've got included. And then recall is what portion of the 403 are in that concept set. Nothing has a recall of 100%, I don't think, but there is one, a diabetes V1 that comes very close. It has 402 of them. And, it's got 547 concepts. So this is a more general diabetes concept set. I could also sort here by concepts. So there are other concept sets, basically what I'm trying to show you here is that by sorting on the number of concepts in the concept sets, how many are shared with those, the precision and the recall, you have a lot of ways of exploring the neighborhood of concept sets around the ones that you have selected. Going back to the comparison page, I just want to show, now we've got nesting of the concepts by the vocabulary hierarchy here, and it can be useful to search around by expanding and collapsing these things. But if you you might want to do some sorting, like which are the ones that have the most patients or things like that. In order to sort, you got to get rid of the nesting, because the nesting is going to be all wrong if you sort by anything. So I've got this button here for going from the 891 that you get when nesting, because a lot of concepts have multiple parents, to the 403 distinct ones. And now, we could sort by, how many patients have an occurrence, how many distinct patients have an occurrence of that. Oh, I just see a bug. Never mind that. We can sort by, we can bring any of our three concept sets, their concepts up to the top. Also, you'll notice, okay, so the check marks tell you which concept is in which concept set. I'm going to go back to the nested. And you'll notice that there are colors here. So the pink means that this concept was included in this concept set, but as a child of something. It was not included directly, but it was included as a result of include descendants or include map to or something like that. If it's orange, then it was both included explicitly in the concept set and included, and it ended up in the concept set after expansion. In these, oh yeah, so here are a couple that are gray, meaning that hypoglycemia due to type 2 diabetes mellitus was included explicitly, perhaps with the exclude flag or the include descendants flag, but for one reason or another, it did not end up in the expansion, but it does end up in the version items. So that's what these three colors mean. I believe I have gone through most of the features here. Let me return to slides for just a moment. So current features, we have access to the concept sets in the enclave, quick selection of multiple concept sets for viewing, access to the properties quickly and many-to-many overlap. Oops, sorry. Those are already implemented features. I meant to say towards the beginning, but what we're looking at is a development implementation on a local machine. We are on our way to getting having a publicly hosted instance running so that this will be available to anybody who wants to come to it. Hope to have that briefly within weeks. Concept set creation is not implemented yet, but we're also very close to that. As well as concept set modification, more metadata display, and searching in the vocabulary neighborhood amongst the vocabularies, as well as in the concept set neighborhood, and also filtering to the most recent version. On the longer term roadmap, we're looking, this is really a platform that's meant for implementing interactive visualization capabilities. So that's where we're headed, to the ability to do subsumption, overlap, patient counts, concept expressions, like intentional concept sets and how they expand, vocabulary navigation, all of that with interactive visualization tools. We're looking to expand to handle data sources and destinations beyond N3C, Odyssey and Atlas instances, VSAC value sets, FHIR value sets, and vocabularies from ontology sources that may not be in the OMOP vocabulary system, for instance. And as we expand to handle those other sources, we'll also be expanding in our tools to be able to use knowledge graph-based data storage and data manipulation that will give us capabilities for doing more advanced graph analytics and visualization. And already we have opportunities to make this go faster. So right now we're not necessarily, this is new development, so we're not focusing so much on optimization, but we can already see a little bit of slowness here and there. So local data caching is going to make this thing just fly. So one might ask, why or when would I use TermHub versus the Enclave concept set browser? So there are a lot of things in the concept set browser that are not in TermHub yet, but there already are some things that may make it worth using. Many-to-many rather than one-to-many comparison view of concept sets, visually clear concept overlap across multiple concept sets, the hierarchy, the nesting right now, and we will be improving that with visualization tools, fast filtering and view of related concept sets, the access from outside the enclave, as we said. And one primary reason to be building this outside the enclave is to be able to use tools and modules and stuff from anywhere we want, which means rapid new feature turnaround. And so there will be more reasons to use it as TermHub grows. Want to thank a bunch of people who have contributed. Joe Flack has put in a lot of programming, as I have, and we've gotten tons of help from the people in DANH and Logic Liaisons and others. And we'll welcome questions. Oh my God, it's 5:56. Well, would love to hear questions.
So no, this is fantastic. Let's see, there is a Q&A, which I can't seem to see for some
Oh,
reason.
I see the question. Where do the precision recall numbers come from? Was this asked before I explained this? I can go back and explain it, but I don't know if I already answered it or not. So the precision is the portion of the concepts in this set on this line that are shared with the selected concept sets. The recall is the portion of the concepts in the union of the selected concept sets that belong to this set. I am curious if I was thinking these numbers might be more useful if they excluded that concept set. So the precision being the portion of concept sets in this shared with all of the selected concept sets except this one. I don't know if that would be confusing. Anyway, people can let me know if I should change those numbers or not. I don't think it's worth having 2 extra columns. But there's my answer to that question.
Great. No, that's very innovative. So a question about will it be possible to export the table of concept sets that you were missing compared to comparison concept sets?
Wait,
Says Kimberly, let's see, I'm trying to parse this myself. Okay. A table of concept sets you were missing. A concept. Okay.
Yeah, maybe Kim.
Your table is A, I want all the sets in B that I don't have.
That you want them where?
The concepts you're missing,
You want
so not the sets, the
Oh,
concepts.
yeah, you just want to add all of the concepts from the other concept set to your concept set. Yes, we could do a yeah, so I think maybe what this is going to look like when we get the editing in place is that you'll make a concept set or you'll choose a concept set to edit. And so say we've chosen diabetic neuropathy, we'll put that column, off to the side a little bit. And instead of just having check marks or blanks, it'll give you a little control, like a plus or minus or something, so that you can include it or exclude it. And yeah, so no reason not to have a select all or deselect all at the top. So yes, Kim, that definitely makes sense as a feature, and yes, we'll have it, and I think not in very long.
Fantastic. All right, thanks. Fascinating. That's really useful stuff. And thanks, Ken and team. And I guess we'll see you not next week. We'll see some of you guys at AMIA week after that. Thanks. Take care.
Bye.